Okay, hello everyone. We have the pleasure of having Dr. Thomas Weimbs on the podcast with us today. Thomas, thanks for your time.
Thank you, Ben. Great to be here.
It's always fun when you get someone on whose research contradicts a lot of things you've heard about the mainstream. And I know you've been studying kidneys and kidney disease for 25 years, and more recently have got into the sort of how metabolic health or metabolic interventions can help with kidney disease. But before we get there, I'd love to start with what is the consensus around kidney disease, and how have we got this wrong?
Yeah, so maybe just to clarify, so when we when we say kidney disease, usually we mean chronic kidney disease, and I would say the by far the most common reason for somebody to get chronic kidney disease is metabolic disease, so type 2 diabetes or pre-diabetes even. Damages the kidneys, due to the high blood glucose levels, due to hypertension, and a number of mechanisms play a role there. So the vast majority of people that have kidney disease, that we would call, have it because of the poor metabolic health, which means that the root cause is really the nutritional lifestyle that's causing the poor metabolic health. And so, unfortunately, the typical treatment for chronic kidney disease does not actually address the root cause of the disease. So, it is essentially just a way of managing the disease and sort of like doctoring on the symptoms, if you will, right? So people get antihypertensive medication, right, to manage their blood pressure, right? But that medication, of course, does not address the root cause of the high blood pressure, for example, right? And and it's been like this essentially forever, more or less. For decades and decades, nephrology has kind of doctored on the symptoms. There are a few medications that are sort of, well, I wouldn't even say they're sort of addressing the root cause. They're kind of like biohacking their way into the root cause, something like SGLT2 inhibitors, and we can go into what those do. So it's a way of biohacking, essentially. I wouldn't even necessarily call this medicine. So essentially the root cause is not currently being addressed. What is recommended to patients is oftentimes really not rooted in science and clinical evidence, but more in almost like hearsay and kind of like tradition, like low protein diets are beneficial, for example. That's kind of out there without actually being backed up very much by clinical evidence.
Yeah, there's this big emerging trend where all these different chronic diseases, if you include kidneys, you can include Alzheimer's, you can include some mental illnesses, that we've been treating the symptoms for years, and now we're digging into the root cause, and metabolic health keeps coming up over and over and over again. What was the tipping point for you where you suddenly looked at metabolic health, specifically in the confines of kidneys and how they function?
Yeah, it was a bit of an accident in the lab, if you will. So we've been studying a genetically determined form of chronic kidney disease. It's called polycystic kidney disease, or PKD for short. So this disease, affects like a pretty large number of people, about 600,000 in the US alone, and millions worldwide. And it leads, it's a progressive disease, leads to end-stage kidney failure by, usually in the 50s of the patients or 60s or so. And we've been studying this using various animal models, rodent models, rats and mice. And we studied like many different signaling pathways, try to understand the underlying mechanisms of the progression of the disease, and found that food restriction is actually very effective in stopping the progression of the disease. And that, was essentially like a crazy idea of a PhD grad student in the lab just to try this. Hey, I want to feed my mice less food. Put them on a food reduction regimen, and surprisingly, that actually worked amazingly. So the progression of the disease was really blunted. And the efficacy, the effect size was just like amazing. So much better than any of the drug approaches we had tried before. Excuse me. So initially we didn't understand the mechanism at all. Why would food reduction have such a profound effect on kidney disease? So we dug deeper, did more experiments, and it took us a few more years to nail it down and show that it's really the metabolic state of ketosis that is important. And in particular, the ketone, the main ketone, beta-hydroxybutyrate. I'm happy to talk about all this. That seems to be very effective in stopping kidney disease progression. So it was really, we were just following the science. Wherever the experiments led us to, we stumble on something and then we try to understand why is it happening, and we do more experiments and kind of work our way forward. But then if you also look at the emerging clinical literature, many people see similar things, both carbohydrate restriction, ketogenic diets, and we have actually now also done clinical trials and helped with clinical trials, and have shown essentially have replicated the same effects that we had seen in animals now also in humans as well. So it's been an interesting journey, coming from a chance discovery and translating it all the way into clinical studies.
I imagine it's such an accolade for keeping your mind open, right? And goes against a lot of the things in traditional medicine I assume you grew up learning. It's funny you mentioned the calorie restriction. I've always wondered, and in papers where they champion calorie restriction, how much of the benefit is actually coming from a nutritional state of ketosis and the ketones being signaling molecules and everything. What do you think about that?
Yeah, no, that's a great question. The literature is full of of calorie restriction studies, right? And usually that's done in like mice and lots of, or even other organisms, and what's usually done is you have a control group of mice, let's say, and they are at libidum fat, which means they have like a mountain of food and they can nibble all day and all night as much as they want. And then you weigh, you measure how much does the control group eat per day. And then you take your intervention group, the mice on the calorie restriction, and you give them a pre-weighed amount of food, that is, let's say, like 23% reduced compared to the control group, which is what we did. And you put that food into the cage once a day. You pre-weigh it, put in once a day, and you assume that nothing else is different. But the only thing that's different is the amount of food that they're eating. But that is actually not true. Another thing that's very different is the feeding behavior of the mice. So if they are at libidum fat and they have free access to food 24/7, they don't really care about when they eat. They just nibble all day long whenever they feel like it. It's like snacking all day long. If you give them a pre-weighed amount of foods only once a day, they've completely changed their behavior, and they think, they know very quickly there's food coming only once a day. I better eat it all right now, right before somebody comes along and takes it away again, right? So, and they actually consume their breakfast, lunch, and dinner, and all the snacks pretty much all at once, in one sitting, and within an hour or two, the food is gone. Which means for the remaining 23 hours in the day, they're actually fasting. So that is different, because if mice are fasting for about 12 hours, they are going into ketosis, right? So they have enough reserves to last them for about 12 hours, which means for, about 12 hours, they are in ketosis. And that had historically never been considered in all of these food restriction, caloric restriction studies. Now that has become very clear. I think the literature is now changing, and people are kind of re-evaluating those old studies and say, hey, this is not caloric restriction, this is actually ketosis, induction of ketosis that's going on there. So I would say the old interpretations were probably not quite right, by just saying, hey, caloric restriction, because you can be in ketosis without restricting your calories, right? You can eat the exact same calories, you can still be in ketosis, with something like a ketogenic diet, for example.
Yes, that makes a lot of sense. I'm interested to see what research that is being attributed to calorie restriction actually was. It's actually the benefit of ketones in the bloodstream. Before we move on to ketones and how they impact the kidneys, I'd love to understand where does this fear of ketosis for kidney issues come from? Is there any literature to support that?
Yeah, so you're absolutely right. Most physicians, I would say, have this fear of ketosis, or fear of anything that starts with keto. And the reason is, the pathological state of ketoacidosis, which is actually completely different from ketosis, which is a physiological process. So they're almost like opposites of each other, but they sound similar and they rhyme, and they both start with keto. And unfortunately, even today, I think medical school textbooks get it completely wrong. They get it mixed up. I've looked at some textbooks, and even nutrition textbooks get this all mixed up. And unfortunately, the authors themselves that write those textbooks don't, I think, understand the difference. So naturally, I think anyone who goes through medical school kind of learns it wrong. And of course, people forget what they have learned as an undergrad, as a pre-med student. I'm teaching hundreds and hundreds of pre-med students every year. And I know for a fact, most of them forget about, 10 minutes after the final exam, forget everything we taught them. And then usually in medical school later, that doesn't get, they don't pick up on that again. So anyone with a medical degree oftentimes doesn't understand the difference between ketosis and ketoacidosis. But what they do learn over and over and over again in medical school and their residency and fellowship and so on is that ketoacidosis is to be avoided at all costs because it kills your patient, which is very true. So that's, I think, where the fear comes from of anything with the word keto in it, which is very unfortunate. I wish we could do something about it, and I wish we could, burn all the old medical school textbooks and rewrite them all, and that will probably take a while. And of course, most clinicians that are practicing today, they have gone through medical school, 20 years ago or something like that. So it's, we need a bit of a revision there, and need to teach people what the difference really is.
I've long thought in the world I operate in, which is startups and things like this, I think any new innovation actually needs a different set of vernacular, needs new words. Because if you're trying to do something new, you need the words to match. You can't use the same old words because people will assume they understand it without having properly understood it. My mum got cancer last summer. She's all clear now. But we started, she started ketogenic metabolic therapy in conjunction with the standard of care. And there was a lot of pushback saying it was going to be really harmful for your kidneys. And that was like a week or two of research being like, well, let's just double check if it is going to be harmful. And actually found a lot of your work during that process. So yeah, misconceptions to be cleared up. So it seems from the literature. Another one is high protein is harmful for the kidneys.
Right.
What do you think about that?
That has been out there again for decades and decades, not founded in any clinical studies, really. But it was, essentially, you can sort of trace it back to one very influential paper by a very influential nephrologist called Barry Brenner, who published in the 80s a paper in the New England Journal of Medicine I would say most people haven't actually read this paper, but it kind of echoes into everything, and made it into all the textbooks. And what Dr. Brenner argued was just based on some animal studies that are probably not very relevant. Using weird species. If you feed a rabbit a lot of meat, for example, that's probably not good for their kidneys, because rabbits are not supposed to eat meat. So you cannot really conclude anything from animal studies like that. But it became sort of ingrained in nephrology practice to almost automatically put any patient with kidney disease on a protein restricted diet, right? So to tell them, hey, you have to be below 0.5 grams per kilogram of body weight or something like that, and ideally even lower, right? So oftentimes, it goes down to 0.6 or maybe even 0.4 grams, some levels that actually cause harm because it's, protein is an essential nutrient, right? So you cannot simply skip eating protein, right? So in contrast to carbs and fats, which are not essential, except for certain fatty acids, protein is the one macronutrient that you just can't cut out of your diet, right? So that is really essential, and you end up with muscle wasting and shortened lifetime of the patient and so on. But there's essentially, studies that were then done over the years usually did not find any benefit of protein restriction with regard to kidney disease. And also, if somebody eats, a good amount of protein every day, they don't get kidney disease. That is not a thing. That doesn't exist, right? So the number one cause of kidney disease is overconsumption of carbohydrates, but not overconsumption of protein. So again, the science in principle is all out there. Nobody practices accordingly because all the guidelines are still out there, and they say, oh yes, you got to be protein restricted because Dr. Brenner said it, 40 years ago in an opinion piece. So that's essentially where we stand.
Okay, well, that makes a lot of sense. So when it comes to a high carbohydrate diet over time causing harm to the kidneys, what mechanistically is going on? Does it have something to do with insulin? Is it inflammatory? What's happening there?
Yeah, good question. So there's a number of mechanisms that all, I think, work together in harming kidneys. So number one is already just the blood sugar, the glucose itself. Very high glucose levels cause damage of critical proteins in the glomerulus, one of the functional unit in the kidney that can cause damage just by simply glycating proteins in there. That's already very well established. The insulin, of course, that comes along with the glucose spikes. The insulin causes hypertension. Somebody who is insulin resistant usually has hypertension. Yeah, that's like the most common cause or the most common effect of it. And hypertension is also very well known to damage kidneys, the microvasculature in there. There's chronic inflammation, same thing. It's highly damaging to kidneys. You have inflammatory immune cells going into the kidney and spraying out cytokines and hurting the kidney. One thing we have been working on in the lab that hasn't been published yet, but it's the paper is in review right now. We've looked at uric acid as a mechanism of kidney damage, and uric acid is one of the waste products, that our kidneys have to deal with and have to excrete through the urine. But it so happens that uric acid does not like to be soluble in acidic conditions. When we have an acidic urine, uric acid actually precipitates in the form of microcrystals in the kidney. And these microcrystals can be highly damaging, highly inflammatory. And we actually found that uric acid very strongly accelerates kidney disease, leads to chronic kidney disease. And we actually think that is probably one of the important mechanisms of most forms of chronic kidney disease out there. So that's something we're working on. We, of course, in that paper already have a solution for it, how to actually prevent these microcrystals, and it's very, very easy to do by just simply alkalinizing the urine pH. So we can do this again in animal models. It completely takes care of the problem and stops the chronic kidney disease progression.
Okay, so if that's what's going wrong downstream of a high carbohydrate diet, I know you've done some work comparing the pharmaceutical interventions. I know you're familiar with that world as well. I'd love to know mechanistically how the sort of number one or two pharmaceutical drugs compare to metabolic intervention.
Right. So I would say probably what has emerged as the miracle drug in nephrology are the SGLT2 inhibitors. They're also called flozins because these drug ends end on the phrase flozin. And so what these drugs do is they inhibit a glucose transporter in the kidney, which makes it so that the patient essentially pees out their blood sugar, right? So anyone with high blood sugar, if you put them on an SGLT2 inhibitor, it essentially lowers the blood sugar level by just simply peeing it out, right? So, and that's what I would call biohacking, right? So then what you would normally do as a logical thinking scientist, if somebody has high blood sugar problems, you would tell them eat less sugar and eat less carbohydrates, right? So to address the root cause of the problem. But what the nephrologists like to do is not tell their patient to eat less carbohydrates, and they just say take this SGLT2 inhibitor pill and pee out the blood sugar on the other end. So rather than addressing the root cause, they're essentially biohacking their way out of the problem. And it is true, of course, it works. You can pee out the blood glucose, and you lower the detrimental impact on the kidneys, so you can slow down kidney disease progression. But it actually really only slows down the progression, but it does not reverse the progression of kidney disease. So the patient gets more years out of their kidney, if you will. And by now, I would say the SGLT2 inhibitors have become standard of care in kidney disease. Nephrologists like to say, hey, let's flozinate our patients, because of flozins, that's the name. So it's a way of doctoring kind of on the problem on the back end, without trying to address the root cause, which I think, to me, I would call that biohacking. I wouldn't really call it medicine.
Just two quick questions on that. One is that approach seems nonsensical when the solution to lower blood glucose, is up front, as you said, just lower your blood glucose by not ingesting so much glucose, right? To then take something downstream, pardon the pun, to lower that does seem silly. Is it perverse incentives with large pharmaceutical companies trying to sell drugs? And my second question, just off the back of that before I forget it, is because the glucose was high, surely insulin still follows. And my question with the drugs is, do they lower glucose fast enough to not have an insulin response, or do you still get the insulin response and in turn lots of downstream effects of that?
Right. So I think you probably improve everything a little bit, but by just peeing out the blood sugar, including the insulin. I'm not quite sure what the effect size is on insulin there in studies. And but why is it clinical practice and to even do this? And of course, the pharmaceutical industry has developed those drugs for a reason, and they need to make money and they need to sell them, so that's understandable. So you can't blame them from developing drugs like that and selling them. But I think one reason why they're so popular amongst kidney doctors is that as a typical nephrologist, in the US and probably worldwide, you have a few minutes with each patient, right? So maybe you have 10 minutes, maybe 15 minutes, when the patient comes and you see them. That is, of course, not enough to teach them how to change their nutrition and lifestyle. Right? You cannot do this in 10 minutes. You need 10 hours for that, right? A nephrologist doesn't have 10 hours, and they cannot follow up like this. And importantly, they don't get paid for this, right? So any medical doctor is essentially running a business. There can be a private practice doctor, there can be in a group clinic, there can be in a hospital, but they can, of course, never lose money. Then they go out of business, right? So they have to, pay the bills just like everyone else. And you cannot do this by spending, 10 hours with each patient because you only get through very few patients in your in the time that you have. So that there's not an incentive to actually address the root cause. There's no financial incentive. But prescribing a pill takes 2 minutes, right? So in your 10-minute session with the patient, you can easily, put it in your computer. Okay, here's a Flozin, take it and come back in 6 months. They can do that. So unfortunately, the whole system is kind of stacked against the proper medical intervention, I would say. There are just absolutely no incentives for it. So I don't know how to address that.
Yeah, it's a story we hear all the time with
Yes, yeah,
cancer, Alzheimer's. I mean, you name it. It's diverse
right,
incentives at play.
yeah.
And you sort of the other side would be a bit aggressive to tax people for being unhealthy, right? You can't really do that. But mechanistically, when it comes to metabolic therapies, what does metabolic therapy do, and how does it protect the kidneys?
Mhm. Yeah, so so we would call it like ketogenic metabolic therapy, or maybe we should actually skip the word ketogenic and just call it metabolic therapy. Yeah.
Yeah, sure, whether to
So
use it.
exactly right. So it's actually, people tend to overthink it. It is actually very, very simple. But you essentially reduce carbohydrate intake and you restrict carbohydrates. That's all you do, right? And then you compensate in the diet, the fats and maybe the proteins, depending on what you're aiming for. But basically, it's just that carbohydrate restriction, right? And carbohydrates means sugars and starches. Those two things. That's it. You don't have to restrict fiber, but in the US, fiber unfortunately are counted towards the carbohydrates, on food labels, which I think is nonsensical because it just doesn't make biochemical sense. So you only have to restrict, sugars and starches. Unfortunately, most lay people oftentimes don't really know what does it mean. What are sugars? What are starches? Even the biology undergrad students, that I'm teaching all day long. It's not clear to them, and I often, when they come to my office hour, I tend to quiz them. Hey, what are starches, and where do you find them? And it's even difficult for them. So I think a little bit of education would go a long way there, and it would make that possible.
It's one of those subjects, though, that I think you need to trial with it yourself to realize how much you can eat of a certain type of food / what's going to kick you out of ketosis and spike your blood sugar, things like this.
Mhm.
Okay, so once someone has figured out how to get in a state of ketosis and their blood concentration of ketones is sufficient, actually, maybe let's start there. Before we understand what ketones actually do to help kidneys, what level of ketones would you say would
Mhm.
be optimal for actually helping various different states of kidney
Good
malfunction?
question. Yeah, good question. We just published a paper, so it's not actually my work. That's the work of Verta Health. They just invited me to, to help out with the manuscript a little bit, and I'm a co-author on the paper. It just came out a few months ago, and maybe some of your viewers might know about Verta Health. It's a company out of the US. The goal is to reverse type 2 diabetes, and they're very successful at it. They're routinely reversing type 2 diabetes in their clients. And they're doing it with a remotely administered nutrition and education program. that teaches people how to do exactly that, but to reduce their carb intake and essentially implement a safe ketogenic diet. They already have over 100,000 patients go through their program, and they very routinely put type 2 diabetes into remission. And of course, many people with chronic kidney disease have also gone through the program, right? So they hadn't really targeted necessarily the chronic kidney disease, they just target the underlying cause, type 2 diabetes. So we looked at data from a study that they had done and looked at patients with chronic kidney disease that had gone through their program. And not to my surprise, but probably to everyone, to nephrologists' surprise, patients actually not only slowed the progression of the chronic kidney disease, they actually improved their kidney function. So it went the other way, right? So you see an increase in kidney function over time. And this was not a short study, this was a 2-year follow-up. So pretty long-term, 2-year study, people on a keto diet for 2 years, asking what happens to their kidneys. And one interesting aspect of the study is that we stratified the data by the ketone levels that patients achieved. And a ketogenic diet, the beautiful thing about a ketogenic diet is you can actually measure how well a patient adheres to the diet by just simply measuring the ketone level, what's the BHB level in the blood. So you can, if somebody cheats and they never get into ketosis, you can see it, right? If somebody adheres really well and then nicely in ketosis, you can see it and document it and prove it. So it turned out that the patients that adhered the best to the keto diet actually improved their kidney function the most. And the best group was around 1 millimolar on average on ketone, on BHB level in the blood. And then, the less well they adhered, the less profound of a benefit they experience. So I think that suggests that there is a dose dependent effect. Of course, I don't think we can say with certainty, this is the amount of BHB you need in your blood. It's I think even those folks that adhered not very well, they still saw an improvement in their kidney function. So I think any bit helps, and maybe the more the better. I'm sure there's a limit at some point.
Yeah, I'm sure. So what mechanistically do you think is the benefit, or what do you think's happening with ketones? Is it, I know they're signaling molecules, so I'm sure it could be doing a number of things. Like what do you think's happening?
Yeah, so that's something we're studying in my lab at UC Santa Barbara. And as you already said, BHB, beta hydroxybutyrate, the main ketone that's made by the liver, is actually not only an energy molecule, but it's not just simply burned for energy, which it is, but that's not all. It's also, I actually consider it a hormone. So it has its own receptor. That's a G protein coupled receptor called GPR109A. And that signals through cyclic AMP inhibition. It also affects many other pathways. It can inhibit the NLRP3 inflammasome and is therefore a potent anti-inflammatory hormone. It can directly affect gene regulation by modifying histones. So histones can be modified by BHB directly, on the amino acid post-translational level. And it has, several other effects that are all sort of like hormone effects, if you will. And all of the effects, if you trace them back, would be renal protective, on different mechanisms, acting on different mechanisms. One obvious one is the anti-inflammatory effect, and inflammation is really a driving factor of chronic kidney disease. So that's something we're studying in the lab quite as well. We have already published some of the studies, and we have actually a lot more that we're putting together, for publication. So the data is going to come out. Interestingly, we had already found and already long published that you can replicate the beneficial effects of a ketogenic diet by just simply supplementing with BHB itself, right? So you take animals with kidney disease, a rat or a mouse, and you don't change their food at all, but you keep them on a normal high carb rodent chow, and you just simply put the BHB into the drinking water, or you can formulate it into the food. And this already replicates the beneficial effects of a strict ketogenic diet in those animals. So that told us that probably the main mechanistic pathway that leads to the renoprotective effect of even of ketogenic diet is the BHB itself. And that actually has led us to also launch a company a few years ago. And we have created a what's called a medical food containing beta-hydroxybutyrate, and it's formulated for people with chronic kidney disease.
Wow. So much to jump in on. I just Googled what a hormone, because I've never heard ketones be described as hormones. So I was like, oh, what's the definition of a hormone? Hormones are chemical messengers produced by the body to regulate various functions and processes. So by that definition, a ketone is exactly a hormone.
Yes, it is, right. Yeah, it's a liver hormone, if you will. The liver makes it, puts it into circulation, and all the other tissues in the body can sense it and react accordingly. So it's the textbook definition of a hormone, right?
Well, I actually think that definition will be more favorable than a signaling molecule, because one, no one knows what a signaling molecule means unless you've been around medical literature and things like this. But two, I think there's an element of seriousness hormones are taken with. And when someone says ketosis, they just think, oh, it's some sort of faddy diet. And they just think, you're one of the people who don't need vaccines. Just here's an essential oil. Like it's not that at all. So I actually really like that definition. I've never thought of it in those terms. The BHB is interesting. Do you think you'd have the same effect with things like MCT oil and ketone precursors, or would the effect just not be as potent as pure BHB?
Yeah, so it would probably help. We have studied it a little bit in animals, and I think the results were not super conclusive yet, and we haven't actually quite put it together yet. So it's still unpublished. So I can't really give you a final answer what MCT alone would do. But certainly MCT oil can bump up ketone levels even without changing the rest of the diet. Yeah, how effective it is compared to exogenous ketone supplementation, for example, I couldn't really tell you. So we haven't done that head-to-head comparison.
Well, they're so effective, exogenous ketones. But I mean, I'm in the UK. I know you're in the US. Are you in the US right now as well?
Mm-hmm. Yeah,
So
in California.
they're fine to have in the US. But if you go back to Europe and the UK, they're all novel. So you can't get anything over here. And actually, I don't think it doesn't look like it's going to be changed anytime soon. So maybe more research. Kind of research you're doing might help pioneer that. So we'll try and get.
I should maybe add for your viewers, for personal use, anyone can essentially buy exogenous BHB products from the US. So, for example, our product Ketocitra ships to pretty much worldwide. And usually for personal use, you can order it, and import it and use it. So there's something for people to know that's actually out there. So, but you're absolutely right. In Europe, BHB products are not officially accepted, and they cannot be distributed inside Europe. Yes, that's right.
I will definitely be ordering some because I'd be very keen to try that. And what I know, I've played with different exogenous ketones before, but never in a food. What millimolar? Let's say you're not in ketosis at all. What millimolar concentration of BHB will you get after eating the food?
Right. So the answer is tricky because it depends how it's formulated. So BHB, beta hydroxybutyrate, comes in two stereoisomers, the D and the L form. The D form is rapidly metabolized, right? So that's the form that's burned for energy, which means if you take a supplement containing only DBHB, you get a bit of a spike initially, after half an hour or so, and then it very quickly drops back down to nothing because your body metabolizes it very quickly. So it doesn't look like much. So maybe you bump it up by 0.5 millimolar or so, but only for a short period of time. The LBHB, however, is not rapidly metabolized, and it kind of like stays and ramps up to higher blood levels. The problem is LBHB, you cannot detect it with the typical ketone monitors. So they are stereo-specific, right? So something like the Keto Mojo and so on, they only measure DBHB. So if you take, our product intentionally is actually formulated as a racemate, which means it's a 50-50 mixture of DNL BHB, but you can only measure the DBHB, and then you see almost nothing. So you're thinking, whoa, it's not doing anything. But the LBHB is definitely there. We can measure it in the lab, for example. And both forms, D and L, have the same hormone function. So they both activate the same receptor and so on. So I would say that the levels you're getting are probably maybe like around a millimolar-ish or so. Except you can't measure it. So people are always disappointed that they take their Keto Mojo and try to see how much of a bump do they get, and they say, hey, there's almost nothing. So it's a little bit hard of a message to explain to people.
Okay, fair enough. Bit of a tricky question. Very fascinating to try that. So we'll definitely try and find a link and put it in the bio for sure. Do you think we can put kidney disease into remission?
Oh, yes, absolutely. That is already can be demonstrated. Not that not that many nephrologists would believe it, because they have usually not seen that their entire career, right? So, they have been treating people day in, day out for years and years and years, and remission doesn't happen with the standard of care currently, right? So even SGLT2 inhibitors only slow the progression. But ketogenic metabolic therapy can absolutely do that. So we have seen this in polycystic kidney disease in a randomized control study. There was only a 3-month study, and we're now doing a 1-year follow-up study that's in full swing. It's looking amazing. We only have interim data, so the study is not completed, but there are already longer term studies on diabetic chronic kidney disease, like the one I mentioned, we just published a few months ago with Verta Health, where there is remission that we can see, right? So people not only slow the progression, they actually improve the kidney function over time. So I think clearly that can be done. It is met with great skepticism, and I think it's just mostly for the reason that standard of the today's nephrology standard of care doesn't achieve that, and people have a hard time, I don't know, being open-minded, that maybe they missed something for all those decades. But yes, remission is possible.
Do you think it could delay or even prevent the need for dialysis in certain patients?
Oh, yes, absolutely. Yeah. So, I mean, even standard of care can already delay, the time to end-stage kidney disease, but if you just use an SGLT2 inhibitor, that slows the progression. But, in theory, I don't see why, I think early intervention is probably a bit of a key here. At some point, there's probably a point of no return. If somebody's at a advanced stage of the kidney disease and the kidneys are a fibrotic mess, there's very little maybe that can be that can stop the progression at that point. But with early intervention, if somebody's at CKD stage 2 or 3, let's say, I think there's a long window of opportunity to actually do something good for the patient.
Well, it's a really hopeful message. I mean, I think this would be a lot of music to a lot of people's ears, I'm sure. Where do you see the next 10, 15 years going in this field? Are you optimistic? Are you hopeful? Are you excited about certain things coming out?
Mhm. Yeah, so we're actually have a nice clinical pipeline. So we're doing clinical studies, and I think that's just key to convince the field that there's something to it. You just have to do the studies, and they have to be well done and controlled, and published by independent investigators, in academic institutions. That's exactly what we're doing. We're collaborating in Japan with Juntendo University, for example. So they're doing a study on polycystic kidney disease. We're starting soon a study at the Cleveland Clinic, also on polycystic kidney disease. We're working with a number of investigators. We're hoping to put a study together with Verta Health, for example, addressing diabetic chronic kidney disease. So I think that is needed that we document the outcomes very clearly in well done studies, publish the results, and eventually this might make it into the clinical guidelines. Of course, as you know, clinical guidelines are typically a decade or two behind the science. So unfortunately, many kidneys will be lost until that actually happens. So I wish we could accelerate things. But on the other hand, the grassroots level, so things what you're doing, right? So any patient with chronic kidney disease can maybe stumble on your podcast, and there's nothing stopping anyone from improving their own health. I think it's in everybody's power to change their own health for the better. So I think what you're doing is actually probably a really good accelerator of translating scientific evidence into clinical practice.
Well, I'm nothing but a vehicle to get wonderful people like yourself on the podcast. So it's all the great work people like yourself do, and yeah, if it helps one person, brilliant. That's great. Thomas, I'd love to finish with some quick fire questions. And by quick fire, they don't need to be so quick, but we'll just see how many we can get through. If you could run any experiment, unlimited budget, no red tape, what would you do?
So I'd probably do a nicely controlled clinical study on maybe on the biggest problem out there, like diabetic chronic kidney disease. Just because the sheer numbers are the most impactful, and we're actually putting together exactly a study like that. And I would put patients with chronic kidney disease on a ketogenic diet training, and that is, I think, the key. You cannot count on a doctor's office visit to make that happen, right? So because no doctor has the time to actually coach a patient, you do need a scalable way of doing this, and an intensive way. And that's actually exactly what we have also done. We have created a nutritional intervention program that is 100% remote, that is led by dietitians, nutritionists, and patients can sign up for it. They go through the program. It's a 3-month intensive training program. They are monitoring themselves. They monitor their blood glucose, their ketones, their blood pressure, body weight, urine pH, and so on. They get all the everything they need. They get their recipes, and they get their one-on-one meetings with dietitians and their group meetings and so on. I think that's the solution to the problem, to actually offer programs like this, where a doctor doesn't have to spend hours and hours with every patient, but they can essentially just refer their patient into a program like this. The patient does it with the support of the doctor, to help, for example, adjust the blood pressure medication over time and so on. And so without any financial constraints, I would love to do a long-term study with this program or a program like this, including our medical food, the exogenous ketones, to actually boost the benefit and to do it in a nice controlled way. With clinical investigators that are top notch in top academic institutions, and they're running the study, but not me, right? So they would run it, and they control the data and they control what gets published and so on. And I'm 100% certain the outcomes will be extremely convincing, and the word would get out there, and probably clinical guidelines would have to adjust and would have to say, all right, fine, this works. The study is there. We can't ignore it. So that might actually change things.
Well, fingers crossed. I'm looking forward to reading it when it comes out, as and when this happens. Would I be right in saying what we're speaking about today would be quackery 25 years ago?
Well, hopefully not that long.
Not
So we're
considered.
Sorry?
Would it have been considered sort of quackery and really out there and off consensus?
Oh, 25 years ago, would people have considered that? No, I think 25 years ago, people would have said, you're crazy. Ketogenic,
Really?
what? Keto kills kidneys. Everyone knows that. People would say. They're still saying it today, right? So I think now is the time. And I actually think metabolic therapy is probably maybe the hottest topic everywhere in all chronic diseases out there. Just the number of clinical studies that are kind of underway is amazing, and results are coming out, and pretty much everything that anyone ever studies, people have really good success with it. So maybe the one disadvantage of metabolic therapy is that it costs essentially nothing, right? And it makes nobody any money. So there is no financial drive to drive things forward, right? So that's completely different with the pharmaceutical industry, right? So 90+% of the clinical studies are funded by the pharmaceutical industry, and there's not much funding available for non-pharmaceutical approaches, unfortunately. So I'm hoping that is something that might change at some point. Hasn't changed yet. The NIH is still not funding anything. If anything, they have cut back down on all the funding. So, yeah.
But things follow the literature eventually, right? Time discovers truth and all that. What do you think today is considered very contrarian? It's not accepted. That will be accepted in the next 10 or 15 years.
Yeah, so I think the whole concept of ketogenic metabolic therapy is currently absolutely not accepted, maybe except for like epilepsy, where people say, okay, fine, if all the drugs fail, okay, let's put this patient on a ketogenic diet, which is also backwards. The ketogenic therapy should be the first line approach. But other than that, it's definitely not accepted. But I'm actually convinced, hopefully 10 years from now, it will be considered medical malpractice to not inform a patient about that option. Especially, for example, type 1 diabetes. I think the science is so clear and the physiology is so clear that you cannot actually treat somebody with type 1 diabetes with a high carb diet and just ask them to keep shooting more and more insulin. To me, that is already medical malpractice today. It's not regarded as such today because that's the guidelines. 10 years from now, I'm hoping it will be as much medical malpractice as lobotomy is today, maybe. So.
Wow. I'm not, without knowing, 1/8 of what you know about anything. I'm of the belief that most chronic diseases are metabolic in nature. Just because I speak to people like yourself, and I speak to Mary Newport about Alzheimer's, I speak to Tom D'Agostino about cancer and Thomas Seyfried about cancer, and just suddenly it all stacks up. Would you agree with that statement that most diseases are metabolic in nature or chronic diseases?
Right. Yeah, absolutely. Right. So if you just, the the typical physician out there, if they would just count the number of patients and what they're coming in every day to the office, probably 80% of them come in with NCDs, these non-communicable chronic diseases that are caused by poor metabolic health. So they usually don't consider it that way, but that's absolutely what it is for sure.
Wow. Well, watch this space. And where can we keep up with your work? Where can we follow you and tune into what you're doing on a daily
Mhm.
basis?
Sure, yeah. People can go to my lab website at UCSB, University of California, Santa Barbara. So all of our publications are there available for free. People can just download the PDFs. I also have a Facebook group that's very popular that has over 4,000 people with polycystic kidney disease in it. And if you just punch in Weimbs Lab, Weimbs, you can easily find it. People can go to santabarbanutrients.com. That's the company we launched that makes this exogenous ketone product, Ketocitra. There's a lot of information there. From there, you can click your way to the social media, including a YouTube channel that we have with, I think, lots of good information as well.
Awesome. Well, Dr. Thomas Weimbs, thank you so much for coming on. That was a real privilege. I learned so much. I knew nothing about any of this before. So, yeah, really appreciate you
Mhm.
coming on.
Awesome. Thanks for having me, Ben. Appreciate it.